and pediatric patient based on the assessment and indication, like site condition, catheter patency, prescribed therapy, or per physician order, or immediately upon suspected contamination. Catheter inserted in an emergency situation where a septic technique has been compromised. New cath should be replaced, like when you receive a code, like if there is code blue in BDAER and you receive the patient after BDAER, like in ICU, you have to change your cannulation as soon as possible because, of course, the aseptic technique has been compromised, preferably within 24 to 48 hours. Regarding dressing change, you'll perform dressing change if the dressing become damp, loosened, and visible soil, and as needed. Aspect technique is followed when providing the site care and the dressing change. Regarding your IV solution, you have to change every 24 hours. When it's complete to 24 hours, you have to discard and renew a new one. Regarding the infusion set, we are changing every 72 hours or every 3 days. Regarding the cannula itself, you have to change the cannula every 3 days, okay? Or if patient in a critical condition, you can extend to 5 days. This is what our policy is saying, okay? For flushing and locking, perform disinfectant of connection service. You have to disinfect the connection service, like the needle nest connector, the injection port before flushing procedure. Assess the catheter function by using 5 ml syringe prior to administration the solutions or the medication. So how you will do, during the initial flush, you will slowly aspirate for the blood return. Check your blood return. If there is a blood return, that's meaning your cannula is good, functioning well. Do not forcefully flush with any syringe size. If you noted the resistant it's met, take further step and check for maybe there is a closed clamp or king side or king on the set to locate the external cause of the obstruction. After confirmations of patency by detection there is no resistance and there is you noted the presence of a blood return, start the infusion. But as we said, you will flush with only 5 ml normal saline. Do not use sterile water for flushing. It's not allowed. Okay? You will document what? First, the number of attempt and the site of the insertion, which is only 3 trial for each nurses. Okay, in our PICU and MCH, we have only 3 trial. Other department, they only have 2 trial for each nurses to try for insert. If you cannot, you can escalate to the supervisor or to ICU, in ICU or BICU to insert the cannula for your patient. Prices, descriptions of the insertion, the site like where encephalic vein, dorsal cervix, or the right lower arm, like this, يعني 2.5 centimeter or 1 inch above the wrist. You have to process the descriptions, size, type, and the length, also the brand of the catheter. I believe that all of us who are using ARCOS documentation. So if you will open the ARCOS, you will find there is documentation for IV cannula insertion or the peripheral cannula insertion. All this, it's written. You have just to refill, which is size, type, and the brand, the number of attempt, and the patient feeling. Also the type of dressing. Then the start time of the infusion, the flow rate, type of IV solutions, and the amount which is infused. Also the patient and patient tolerance of the insertion procedure and the solution infusion. Patient and family education, and the unexpected outcome related to the related interventions. Like you have to educate your patient, especially adult, if there is any pain, any redness, any swelling, you have to inform the nurse. Of a IV cannula. Catheter should be removed by physician's order or if expired. Okay, so step for removal. You will discontinue first the administration of all the infusion. You should to wear the gloves during the CIV infusion. Do not use just your single hands. So first prior, you will wear your gown, your PPE, You will do hand hygiene, and you will discontinue the IV infusion. Carefully remove the dressing from the IV sites and place two fingers of the non-dominant hand lightly above the taft skin junction site with the gauze between the fingers. If the dressing is too much sticky and you cannot remove, you can use the alcohol swab or the spray. There is a medical spray we are using in our ICU. It's called the medical adhesive remover. You can use the medical adhesive remover to remove the dressing, or by alcohol swab, so you cannot remove the patient's skin with you or the hair skin. Then you will use the other hand to withdraw the catheter slowly and equal to the skin and inspect the catheter tip. Apply a pressure to the site for the minimum of 30 seconds or until the bleeding has stopped. Apply an adhesive dressing to the insertion site. Inform the physician if you noted any infiltration of the site or extravasation. And then you will document of the removal for IV cat. So here I added one video. It will explain easily what I am saying. So you can see how we will remove the cannula in the right way.
Now I'm going to remove the IV. And to remove the IV, it's very simple. We're going to remove all the tape from the IV first. So we're just going to lightly just tear this off. And this over here. And you want to stabilize the IV as well because you don't want to just rip that out. Okay, once you have all your surrounding tape off, you're going to take your gauze and you are going to just put it over here because you're going to be sliding this cannula out. So we're going to take everything and grab and pull our cannula in one smooth motion, hold pressure, inspect your cannula, make sure everything is intact, everything looks great. We're going to hold firm pressure for about 2 to 3 minutes, and you really want to hold pressure because you don't want blood to seep under their skin and cause a nasty bruise. And this is especially true for patients who are on anticoagulants. You will probably have to hold this even longer and just make sure that it's firm pressure. Then dispose of this in the receptacle area that your facility requires you to dispose these types of things in. Then once you have held pressure for the specific amount of time, you want to just lift up the gauze and make sure the site's not bleeding anymore, and our site looks great. And what we're going to do is we're going to take some tape and we're just going to tape over the gauze and keep that like that. And then what we're going to do is we're going to remove our gloves, perform hand hygiene, and document that.
Okay. So after removal, I added the pediatric concentrations. So in pediatric, the venous access site, it's hand foot. Also, we can use the scalp, but scalp only by trained staff, like the ICU and in ICU staff only, or in the wards by only the trained staff who can use the scalp to prevent any complications to the infants. Employee distraction. Use distractions during insertion like toys, videos, or if you have in your hospital the child life specialists, or you can use the parents. Use stabilization like armboard or warps to prevent dislodgement. At the end, you can use the topical anesthetic, engaging parents or assist the sites every hour. Regarding anesthetic only by doctor's order. Okay, so pediatric patients require the specialized IV care to minimize the attempt to bear nurses use to bear nurses. Okay, so you can use the topical anesthetic like lidocaine cream, of course. after you confirm the order with the doctor, and involve the parent as active support persons throughout the procedure. Okay, I add this card to see the vein axis for IV cannula in children. So I will add this one as a card so you can review it easily to see where the upper limbs and the lower limb. Okay, and I add here the principles, the tips for success, and you can see here the cannula size gauge and the selections guide. Of course, for the vein selection guide, I have to just review this one. We have the factors depending on patient age, hydrations, the patient conditions, and the previous access. I cannot enlarge here, but I will add this card to you so you can review as a pictures or keep it for you, yani, to review. Then we have the older adult concentrations. Of course, in older elderly patients, fragile veins prone to ruptures, handle with a minimum tourniquet pressure. Do not do too much tourniquet because you will turn the vein. You will destroy the vein. Modify or omit the tourniquet to reduce the vein trauma in an elderly patient. Reduce the skin integrity and the subcutaneous tissue. Use gentle tourniquet. Use a shared insertion angle. Prefer 22 gauge catheter for frail patients. In elderly patients, they are required adapted IV techniques. Assess the vein fragility, minimize the trauma, and select the smallest effective cath gauge to ensure patient safety and comfort. We will proceed to the IV complication. For IV complication, we will start with the phlebitis. What is the phlebitis? It's inflammations of the vein. What's the sign and symptom? You can see there is erythema, warmth, swelling, induration like skin fireman, and you can notice the pus or the bilable vein score. Okay, so what you're gonna do as a nurse, you will stop the infusion, you will remove the cannula, and notify the physicians about the sign and symptoms. Of course, we will apply a warm compressor as ordered and elevate the limb. Okay, and there is a scale to monitor the sign of a phlebitis, yani the worsen. +1 is erythema to access site with or without pain. +2 pain at access site with erythema or edema. +3 pain to access site with erythema, streak formations, bilable vein score. Fourth is the worsen, which is a pain at accessible site with erythema, streak formation, bilable vein scored 1 inch in length, and the purulent range. So what you will do, you will replace the IV, use a new site, apply a warm compressor, monitor hourly. Next, we will proceed with infiltration and extravasation. Infiltration and extravasation. Infiltration, the meaning leaking of a fluid or medication into the surrounding tissue. Okay, there is leaking from the cannula, from the puncture site. What you will see cold skin, edema, pallor, and pain. For extravasation, it's the opposite. It's leak of damaging medication, viscant medication like tazocine or vancomycin into the surrounding tissue. Okay, that is damaging. What you're gonna see a warm skin, edema, rednesses, and pain. In other conditions, of course, there is blistering. What you're gonna do, you will discontinue your IV, apply a cold compressor, administer the antidote as ordered. And for both, we will monitor hourly. Extra step I will give to you, which is immediately stop the infusion, notify your doctors, discontinue the administration set from the catheter hub, and aspirate from the cath with a small syringe. Aspirate the viscant drug or what you are giving, especially in extravasation. You have to aspirate. Do not remove the cannula. First, you have to aspirate and then you will remove. Do not remove before aspirating. Okay? Use a skin marker, outline the area with a visible sign to allow for assessing changes. And never apply pressure. You will just put the compressor without a pressure. And of course, you will give antidote according to doctor's order.